So this was a 42 years old male presented with QS complex in the 2-3 AVF, lead in the ECG, and CAD-SCS evolved inferior wall ST elevation MI. He was thrombolized with the tentaplase yesterday in some local hospital, and then today he presented to us. He don't have a chest pain right now, and vitals was normal, BP normal, and heart rate was normal. And this is the iliocaudal view. There's a ariocaudal view. Everything is normal in OM. This major OM, there's a mild lesion in the proximal. There's again the cranial view, and the same thing in this major OM there was a lesion. And LAD is ariocranial view, LAD is normal. With the JR catheter, this is the expected. This is the inferior wall evolved ST elevation MI, thrombolized with the tentaplase outside yesterday, and this is the picture on the total thrombotic occlusions in the RCA, mid RCA. So decided to do the angioplasty. So this is a BMW PTCA wire with right radial root. We went ahead after clearance, and this is the JR catheter, and you can see there is no support with this catheter. Catheter is hanging in this large RCA. This RCA is around 3.5 to 4, and this catheter is hanging around them. We crossed the wire in the lesion, and it took me around 5 minutes with this whisper wire. It was not crossed with the BMW workhorse wire, so I took whisper wire, changed to whisper wire, and then it crossed in 5 minutes. So you could see there's a flow in the RCA, but everywhere thrombus is there. So from the site of occlusion to the mid RCA, I decided to put a stent without doing thrombosuction, because thrombus may go here and there. So I decided to plaster the thrombus between the stent and the vessel wall. So I decided to take 3.5 into 24 stent in mid RCA right from the lesion. But as usual, there was no support in this large RCA with the JR, so I need to change the catheter, and we changed the catheter into 3D RCA guide catheter. This is 3D RCA, and it fixed, it almost engaged very well. And then we placed the stent over there right from the thrombotic occlusions, and then deployed the stent. The stent was 3.5 into 24 and deployed at 14 atmospheric pressure. And this is the picture after the stent deployment. RCA has opened up. In the bifurcation, there's a PDA-PLV. There was a thrombus, but was open, and what you could see is just below the stent there was some, just near the arrow you could see there is a thrombus, or we thought of dissection might have happened, but there was no dissection. We thought of dissection, but this was a thrombus. We took RO lateral view. This was the RO plain RO extreme view, and you could see there is no dissection. It was a thrombus which was pushed by earlier stent down in the vessel, and again we decided to put a second stent in the mid RCA. Even if it is dissection, it will treat. So now it was hard to put a stent from this earlier stent, so now we took a 3.5 into 18 stent, and this is a stent placement, and we took a stent boost for the overlapping. There's a stent boost, and we overlapped the stent, and this was the positioning of the stent, and then deployed the stent, and this was overlapping. We had done overlapped, and this was the scene after the stent deployment, second stent deployment. So this is the scene after the stent deployment. So this is the scene after. This is a cranial view, and you can see the RCA and all its branches. Just at the distal RCA PDA-PLV there was a thrombus, but In this condition, we can't do anything. So we started the patient on tirofibin, and now whole RCA has opened up. It's a big RCA, and this was angioplasty in post thrombolytic patient in the inferior wall ST elevation evolved MI. Patient was stable and shifted to ICU.